And so before we introduce our speakers for today, I wanted to welcome everyone to the first of our Colorado Pragmatic Research in Health seminar series on methods for planning pragmatic research. And this seminar series is a continuation of our conference that we held this summer that we called COPRH. And so I'm Bethany Kwan. I'm the Director of Education for the Adult and Child Consortium for Health Outcomes Research and Delivery Science at the University of Colorado Anschutz Medical Campus. Quite a mouthful there. And so we're so glad to have everyone join us for our seminar series. And if you didn't attend COPRH, we do have all of the content recorded from the virtual conference up on our website, and you're welcome to go view it all. It's all there and free to access. And of course, our seminar series is also free. And our first seminar today will be starting in just a moment, but I also want to bring your attention to some upcoming seminars. First, on stakeholder engagement methods for planning pragmatic research, our own Chris Knapke at the University of Colorado presenting on the audio elicitation interviewing method. And then in January, Dr. Jody Summers-Holtrip and Linda Zittelman, also from the University of Colorado, will be presenting on use of frameworks and models for planning pragmatic research, specifically focused on implementing technology and medication-assisted team training and treatment in rural Colorado. It's the It Matters study. Jordan, could you go to the next page, please? There you go. And so our seminar series and the conference series is part of our COPRH virtual learning community. And anyone is invited to join our learning community, learn from each other, help contribute to identifying gaps in evidence around application of pragmatic research methods in health. And you can see the link to our virtual learning community there. Anyone's welcome to join. And we will have a newsletter coming out this week for anyone who's already signed up. And then we'd also like to announce our new blog, which we call the Pragmatic Scientist. And our first blog post is live today on shared values for pragmatic research in health. And you can see there's a little tiny URL link there that you can enter directly into your web browser to access. And there's just a little bit of background around learning communities and how they work and what we're imagining for the COPRH learning community. We have a couple discussion questions we would love to have you answer through the form on the website, really thinking about what are the important norms, beliefs, and values underlying pragmatic research in health, and how do we develop a more collaborative culture in pragmatic research in health. So we'd love for you to go check that out and join us in the conversation. So with that, I'm going to introduce our speakers for today. And so Sarah, will you be sharing your slides now?
I will.
All right. So while Sarah is bringing up her slides, Dr. Sarah Brewer is an assistant professor in the Department of Family Medicine at the University of Colorado Anschutz Medical Campus. She's the associate director for the Colorado Children's Outcomes Network, or COCONet, which is a practice-based research network in Colorado. She has experience in designing and conducting health services and patient-centered outcomes research using qualitative, quantitative, and mixed methods. And her research interests concern disease prevention and establishment of healthy behavior in pediatric care settings, considering the role of community in refugee health during resettlement, and effective implementation of community engagement in health outcomes research in the healthcare system. She is joined today by her community partner, Dr. Maki Gboro. Did I say that close?
Yes.
Great. Dr. Gboro is an analyst at the Colorado Health and Environment Data as part of our public health department, and is working on his master's in public health at the Colorado School of Public Health. He completed his doctoral degree in practice medicine in the Democratic Republic of the Congo before moving to the US. And he partners with community-based organizations, researchers, and medical providers working with refugees and immigrants in the Denver metro area to improve access and utilization of healthcare resources. In his free time, he loves to spend time with his family and friends to play tennis, ping pong, and soccer. We're very active. I hope you have time for it all. But anyway, welcome, Dr. Brewer and Dr. Gboro. here to talk to us about how to create a community-based research network for engaging refugees and improving refugee health. Thank you.
Thank you, Bethany. So that was a nice introduction to us. We can skip our slide where we were going to introduce ourselves. I'll start, well, maybe I can advance our slides. I'll start with, we don't have any disclosures today, but I do want to acknowledge that the project we're talking about was funded through PCORI through an engagement award. And so today we're going to introduce ourselves. We'll talk a little bit about how we came to this work and our backgrounds. And then we've got sort of 3 phases of the work that we're going to talk through. First was developing our community-based research network board. Second was using that board and working with that board to identify issues from the community perspective around refugee health. And then prioritizing those topics to really solidify a research agenda for moving forward with this group. So I'll talk a little bit about myself and how I came to this work, and then I'll have Maki do the same. So I have been doing community-based research work for nearly 15 years and have done a little bit of work with refugee communities nearly a decade ago, and did through our CTSA, our community or our clinical and translational sciences group here in Colorado, had done an immersion program getting to know health issues in our refugee community locally. And the experience was really intended to sort of set junior researchers up to write pilot projects with community partners. And one of the things I learned coming out of that immersion experience was there's really a need to build capacity for refugee community partners to work with researchers before we could really dive into conducting research projects. And so that really spurred the idea for this project to bring people to the table to lay that groundwork before diving into research projects. And I think that's a piece of what we're going to talk about today around really being pragmatic, that we were not at a place where we were ready to dive into starting to collect data and design a research study. We needed to build the relationships and the capacity for us and for the community to be able to do that together. So that's sort of how I came to start this work. Maki, do you want to say anything about how you sort of came to this?
Sure. Briefly, maybe. When I moved back in the US, I had a chance to kind of help refugees to navigate in the healthcare system. I was working with one of the resettlement agencies, and I saw how hard that was for like newly resettled refugees to navigate the healthcare system. And at that time was only the medical piece of the healthcare system. So myself, I experienced some issues because I have one of my son who was diagnosed with autism, and it was quite a really big challenge to even accessing those like special services. And having some background in medical field, I was thinking like maybe it won't be such a challenge, but I found that even for people who are really in like a feel comfortable, they may still face those kinds of challenge. So since then, I've been involved to kind of support our community, to like in general, like immigrants who are struggling to access care. Even talk with a lot of providers how they can improve the healthcare practice and services just to kind of increase that accessibility. And I think we met with Sarah and in one of the conference seminar here on Anschluss campus, where they're discussing about community involvement. And we get to know each other, and I was shared about the project, and I feel like it was really a great opportunity to bring like people, especially refugees, to the table, especially like we never see like refugees like in a research or in discussing those kind of topics. So that's why I found that was very great opportunity to kind of voices the opinion. So that's why I get on the project.
Yeah. So I'm going to talk through, like I said, the next step, developing the board, and how we sort of started this process of building the capacity and thinking about a structure that might support that integration of refugee community members into really our research enterprise, and thinking about how those sort of come together. So we started with this idea of what does this even look like? And we came up with this idea of a community-based research network. So as Bethany said in my introduction, one of my roles is Associate Director of our pediatric practice-based research network here in the state of Colorado. And that structure of thinking about this network of practices that work together on issues they all see as relevant to their clinical work provided a sort of framework for us to think about this for the refugee community. So we sort of adopted some of that and came up with this idea of a community-based research network. And the idea being that we have health researchers who are interested in solving problems and really pursuing health equity for refugee communities. We have the refugee community who obviously have an interest in that. And then we also have refugee community organizations who are serving this population. And really thinking about what's that nexus of where we can bring all those stakeholders together to really think about how to pursue improved refugee health together. So we took both a health equity lens and a community-based participatory research lens to finding that nexus and thinking about bringing people together in that space. And then we had to think about creating a structure for that. So how do we support collaboration amongst these groups? How do we bring people together at the same table to have conversations that equitably bring all those voices to our conversations? And particularly, we wanted to keep a focus on being driven by the perspectives of the refugee community that are often neglected in thinking about refugee health. So we found very few examples of other groups who are really putting the refugee voice at the center of all the phases of doing research around refugee health. So I think that was something that was really important for us, was again finding that space in the middle to bring people together. I want to share a little bit about the refugee community. So here in Denver, it's a very diverse community, and it looks a little bit different across the country, but I'll talk specifically to Colorado. So, and I'm going to use data from 2015 because Maki and I talked about this a lot. When we talk about the last couple of years, there have been some policy changes and some resettlement differences. We really think 2015 data represents a lot of our community here in the Colorado area. And we're hoping that it also reflects where we might be headed in terms of refugee resettlement and the refugee community here. So in 2015, Colorado resettled about 2,300 refugees, and about 90% of those settled in the Denver metro area. So a pretty urban space. Colorado welcomes about 2% of the refugees that are resettled in the United States each year. And then we know that diverse population coming from numerous countries around the world face a lot of barriers when they arrive. So they're facing barriers in terms of financial security, in terms of access to healthcare, language barriers. So only about 18% of refugees in Colorado in 2015 spoke English at home. And then just navigating systems. So learning how to use transportation, learning to read English so that they can navigate through the world are some of the barriers that the population faces in terms of building that life and being able to engage in things like healthcare and healthcare research. So when we looked at sort of this diagram of thinking about building a community-based research network, we didn't think about a process. How do we actually start to build something in that nexus of stakeholders? So our team at the university started by building a steering committee. And the idea here was that eventually we want to have a board that is representative of the diversity in the community, and we need to bring people to the table who can help us build that. So we started with 2 refugee service provider leaders, our state refugee health coordinator, 3 leaders from the refugee community, another community-based participatory research user at the university who had also worked with refugee communities in the past, and then our 3 team members. Oh, sorry. And we started with that steering committee of really diving into what could this look like, who needs to be at the table, who do we need to talk to, and those discussions led us to doing informational meetings with over 50 organizations and stakeholders in the Denver area. And these were short meetings to really just get the lay of the land. And that's how we really talked about and approached this, was tell us about the work that you're doing, tell us about the struggles and assets you see in the community. Think about what are some of the key topics and areas that your organization or you personally are working on in terms of refugee health, and who are the other people we need to talk to. So who else is doing work with this community, and who might need to be at the table for this concept of a community-based research network board. So we did, like I said, about between 50 and 75 of those meetings, depending on how you count some of the conversations we had more broadly, and ultimately ended up inviting 18 community leaders to join our board. And all 18 accepted and came to our launch meeting for this community-based research network board. Plus then our 3 project team members from the university. And what we asked of them at that first meeting was to commit to a year, work with us for a year to build this infrastructure up. So I want to share an invitation that we sent. So everybody who came to our launch meeting received this as sort of the start of that conversation of whether they were willing to join this. So rather than putting out like a job description, or we'll often see sort of short paragraphs of like, are you interested in being on a board? Come talk to us. We really wanted people to have some information about this, and we wanted it to look catchy and exciting. So I'll just walk through this really briefly. The goals of the board, what were we really trying to do? What they would get out of it. So, you know, the opportunity to really have an impact on refugee health in the community, as sort of the big picture things that people might gain, but also down to the nitty-gritty of, you know, providing babysitting and dinner at our meetings. So people were getting something tangible each time we met with them. And then some of the sort of duties and responsibilities we'd be asking of people. So I think this is something that PCORI really found valuable and has shared in their resource repository. But for us, we also had really positive feedback that this was a resource and document that our community members really felt spoke to them and clearly conveyed what they were getting themselves into. And then I want to share what we did at that launch meeting. So, you know, we think that working with community, one of the most important things is building that community, being able to have some time to eat together, to break bread, to socialize. So we came up with, this is how we started every one of our board meetings, was meet and greet and eat. And then for our lunch meeting, we actually spent the majority of our time getting to know each other. We did long form introductions, really getting to know what people are doing in their community, what people's family lives are like, what their hobbies and what they do in their free time. And this was led by one of our steering committee members who was a member of the refugee community. And then we spent some time walking through this piece I just explained to you guys of what's our concept, what are we doing here, why is this important? And then spent some time walking through the role that people were committing to, having people actually commit to that. So we spent some time having people say, yes, I'm on board. And then you'll see we started this agenda with our objectives. And this is something else we carried through every board meeting. We would have our objectives at the top of the agenda, and we would go over those objectives at the end of every meeting and confirm that we got there as a sort of group evaluation of our process. And then I want to highlight, before I pass over to Maki for our next phase, the diversity of our board. I said we had 18 members invited and attend that first meeting. And this is a photo from our launch of our Community-Based Research Network board. But I want to point out we had, I believe it's 13 countries represented and well over 20 languages represented in the room. I'm going to jump back real quick, in part because we're covering pragmatic research and what it looks like to really do this kind of work in the community. One of the conversations that we had over and over with our steering committee was about how we were going to create a board that had that kind of diversity. And you'll see down here, successful board members would be able to speak conversational English. And this was something we really debated over and over, how to make sure we could have representation of this community where in Aurora, Colorado, we have over 120 languages represented in Aurora, but also be able to really function as a board and move forward. So we mulled over lots of different approaches to this, of having sort of headphone interpretation for every board meeting, all the way to this requirement of speaking English. And ultimately, we landed on the board functioning in English and really being intentional about recruiting people to that board who could really be liaisons to the community and represent the needs and perspectives of the community and help be a bridge. So we had to kind of compromise on that in order to function effectively and also meet some of our representation goals. So Maki, I'm going to pass it over to you to talk about what we did next in terms of the tasks of the board.
Thank you, Sarah. So after we established our board, our first goal was to learn what are the main concerns, like the health concerns from our refugees community. So we proceed by going to them and delivering like interviews. And the way we did that, we want to make sure that we can be very culturally sensitive. So the team of interviewer were kind of composed with one researcher and one of the community leaders. And that was really a really big benefit to this because we thought that community leaders could be our brokers, like a cultural broker. And they were very, the community leaders we are selecting to each interview were matched with the family we are planning to visit. And so we didn't have to hire like a new interpreter to come to those meetings. So our community board members were able to serve as an interpreter at the same time. Another benefit of this was that this ownership of the project, by participating on an interview, like we as a community members, like board members, we kind of own this project and feel like we are kind of increasing our partnership in this research. So the CBRN also train community navigators from those people who are members of the team, like the interview team, we only use like 4 members of the community board member, but we also partner with one of the agencies here, local agencies, which support the refugee community, the Colorado African Organization. So we recruit 4 of those community members. We use them during our interview process. And during those training, the, uh, the the community members were kind of they discussed about different technique about how to deliver interviews, and also they kind of go in depth of reviewing all the process of the interview, and things like how that's happened, how to make to take note and things like that. We also make sure that we can have like debriefing like on after each interview, so people can be more comfortable, and also we can even modify the interview guide we have, because things should be adjusted based on the situation kind of we are facing. And to be compliant with the IRB, we also have some training in the, like the board will train also on human subject research. And I think everybody had that training except I think 2 of the board members would have a chance to attend those meetings. And during those interviews, because we thought that everybody was ready to help. Everybody want to do something, and we want to we want to make sure that all the members who will be able to collect data and go to the community could be covered by those certification. So in total, we deliver 55 interviews. And as you can see, 49 of those interviews were from refugees family. And if you see on those country of origins, those are like most of the origin of families we kind of interviewed. And this population, like those countries represents, I think, 80% of the recently resettled refugees in the last 5 years, based on what Sarah said earlier today. We consider like the 2015 because there's been a lot of changes. So that means that we cover kind of a big portion, kind of it's not like a big, we cannot say it's a sample, but we kind of found ourselves like talking to a diverse community. But another thing also we did, we had a chance to interview service providers, especially healthcare coordinators from resettlement agencies. But also we talked to mental health and medical providers who interact with refugees. And it was very interesting experience. And as a community member of the board, we thought that we were really engaged in this project, and we didn't limit our engagement only on collecting data, because we also participate on a different phase of this project during the analysis, because a few members participate on coding process of those interviews. And what we're doing, we sometimes we're doing like individual coding of those transcripts, and also we are meeting with 1 or 3 research team members to discuss and compare the transcript and see if there is any consistency across the team. So after that, I don't know if Sarah can go to the next page. I want to show what we did find. So those are the main area of concern, which was raised during our interview after we collect that. But before to move to this, I forgot to say something, because after we analyze those transcripts, we usually go back to the community board to get them involved and see if they were kind of agreeing with what we've been done. So these are the list. This is a list of the health concern we did find through our interviews. So it's not like, so this list is not like in a particular order. So it's just bullet point because we didn't categorize them. So as we can see, we have health concern, healthcare system, which is still like a big concern for recently arrived refugees, because the healthcare system is very, very complicated in the US. And not only for refugees, but I think even for people residing in Colorado, they still face those kind of challenge. Many refugees don't have insurances in their countries, and those are kind of very kind of big challenge they face when they come to access the healthcare system. And how many people know when to use urgent care or emergency, and when to go to a medical service like a medical provider? It's very a lot of confusing step on the refugee side. And another thing is, I know most of refugees, when they arrive in the country, they are covered with Medicaid for the few months of the stay. But as they start to work, even though they don't make enough money, they kind of become ineligible to Medicaid, and the cost of care become very, very expensive. And that we can see how that can limit the access to health and even deteriorate the health system, the healthcare. And another point was very interesting was the refugees mentioned that life was difficult in the US. That was very something where I couldn't, it was very interesting because this was based on the previous experience, like from the countries and from the refugee camp. I know many refugees during the interviews bring this that the life in US is very stressful because of the schedule. Everything is running on schedule, and is beside the challenges they're having, such as language barriers or biases, they still have like a lot of struggle to kind of access well-paid jobs, and also they miss also a lot of those like time they spend like together, like entertaining each other or family time. And also they feel like they start to lose some cultural norms and values, because most of the refugees say that they did not, but when they were back home, they used to have time to spend together, to relax, and they don't have those kind of opportunity in the US, because they still have like the cost of life is very difficult and it's too high, and they have to work hard to in order, and they don't have time for themselves and for their families. And all those things can really bring like a mental and even physical exhaustion to them. So those are kind of things, like few things like refugees did mention. And I don't know if Sarah, you have something to add, or we can go to the prioritization topic.
I think we'll go ahead and continue and make sure we have some time for questions and answers, because I see some questions popping up in the chat too.
Okay.
So once we identified that big long list of issues, we sort of expected that to happen, that we would have a long list of issues. We really knew we needed to prioritize that. We all have limited sort of resources and time and ability to move things forward, and so we really wanted to understand what are the top issues that really need to be the focus of our work as a CBRN moving forward. And so I'm going to describe the process we used for engaging the community to really help us prioritize those and identify the things that were most important, should be sort of top of our list moving into the future. So we used a process called Nominal Group Technique. The CDC has some guidance on this. It's been used in some other settings. But the idea here is that Nominal Group Technique process prevents domination of discussion by a single person. So rather than having community meetings where one person might be able to stand up and sort of be the voice of the community, this really democratizes the process and allows us to really hear from everybody who participates in the process. it encourages everyone to participate. So there's a process in which people, everyone at a table or everybody in a group has a role to play and can really participate in that discussion. And it results in this beautiful quantized list of prioritized solutions or recommendations that represent the group as a whole. And I think one of the things that is also really great about nominal group technique is that it can really be tailored to whatever questions you need to ask of the community. So we specifically asked about which of these things needs more research attention, what should be our priority in terms of research, but it can be used for identifying assets in the community. It can be used for identifying solutions or recommendations around particular issues. So it's really flexible in terms of the topics that it can be used for. So how do you conduct a nominal group technique? What does it look like? You start by sharing existing data. So the moderators of the process present data or evidence on topics related to the questions you're about to ask. So in really thinking about, what do we already know? What can we create some expertise around in the group before we dig into prioritizing? Next, you generate ideas. So everybody who's in attendance at the NGT is given some time to reflect on the data that you've shared with them, but also on their own experiences to summarize that into their own list of priority areas and ideas for how to answer the question. Next, you record those. So you go sort of round robin around the room. Everybody gets to share one idea at a time. Those ideas are recorded on a flip chart that, at our events at least, we'd have flip charts on walls all the way around the group. But you want those up where everybody can see all the ideas that have been shared. And you go until everybody's sort of gone through their list of the ideas they generated in step one. Step 3, you discuss those. So you set a time limit. You say, for 10 minutes, we're going to talk about these. What questions do people have? What clarification about the ideas we've put on the wall? So we have an opportunity also to split ideas out. So if somebody put mental health up, you could split that into anxiety and depression if the group felt like those were sufficiently distinct. But you can also combine things. So if the group says, anxiety's up there and depression's up there, but those are really all under access to mental health care. And if the group agrees, you can combine those. And this is an opportunity in the process to do that. And then you can vote on ideas. So there's a process where people write down their top 5 of the ideas that are up on the flip chart papers. And then you go through and their top issue out of the 5, their least important out of the 5, and it assigns vote points to these, which can then be tallied up, and that gives you the quantifiability of the outcomes here. So I've walked through the process we used, but Maki's gonna talk about what that actually looked like. Maki helped to facilitate some of these, along with a number of our other CBRN board members. So he's gonna walk through what this actually looked like for our group.
Thank you, Sarah. So what we did, it was very great experience, very engaging, and the refugee community were very enthusiastic about this. So we had about 5 community meetings, and that was across like the 3 months. And we had, I think, about 68 refugees members participating during those nominal group technique. And as Sarah mentioned, community board members were also co-facilitator of those meetings, and they were engaged during all the process, and it was very, very fun. And what we did is we kind of we present our data coming from the refugee health data from the CDC, but also we use data from the RISE study, which is like the integrated survey and evaluation. And we use also a few of the data we got from the interviews at the beginning. So we kind of describe those to our refugees because normally what we planned in the beginning was supposed to do break those groups, like a small group and work in small group, but it was so difficult to organize like communities in different like a small group. So we kind of grab them in just a one group and go from there. And after we did that, we, as Sarah mentioned, we also go through the process of nominal group technique. And it was very engaging. We're coming, especially when you're asking them to brainstorm about their health concerns. We're having like a concern we couldn't expect. So which were not even obviously health related, but community members by themselves with on their own words were showing us how those topics they're mentioning were affecting their health. So an example is like one of the session community members brought the fact that they felt like they were having some discrimination at work, and they were asking themselves like, how do you feel like this can affect your health? And they're explaining to us how having those discrimination at work was stressing them, even when they're going back to back home, they're bringing that stress at home, affecting the relation in the family. So it was very interesting. So we after we did the brainstorming, we also kind of share the data with them. So like give them time to ask questions and ask them to collect that, to select the top one. And this is a sheet we can see like how we kind of writing on a whiteboard. It was not a whiteboard, but it was like a big uh, white sheet where we are presenting and categorize what they mentioned and the voting system, how it's happened. And Sarah, if you can go to the next slide so I can talk about the health. So this is like the CDC refugee health priorities. And on the left side this is like from the Colorado Department of Human Services and the refugee, like the CRISP services, what they think being refugees' main concerns. And on the next slide, sorry, you wanna go to the next slide, please? So refugees, after this is like when we have, because we have 5 meetings, as I mentioned, and when we put those data together, we came to this prioritization of health concern in a community, in a refugee community. So the first of the challenge they found was the language barrier, and that is kind of really expected because we know that as I mentioned, that the healthcare system is very complicated. When you have like those, like the challenge of communicating, it can really alter your health, not hurt your health, but also how you can access the healthcare system. Refugees did mention during those during those nominal group technique that they have hard time to communicate with their provider. They cannot even schedule appointment when they need to. And sometimes they don't even understand what the provider telling them. Even though many providers have like interpreter, sometimes the refugees community is so diverse that even though they may be saying they're speaking the same language, but there's still like different understanding and level. There's still like some sub-categorization within those languages. And I mentioned like the challenges of navigating the healthcare system. This also came during the nominal group technique. And also another area of concern was the mental health, which was related to the depressions, which I think maybe due to the background. Refugees were go through a lot of stress from not just after resettlement, even before that, even from the country or refugee camp, that can be kind of expected. That point was raised among the main one. And also, I don't know, Sarah, do you have anything to add?
No, I want to point out that this is sort of a synthesis of 5 different NGT processes that we had to combine. And so I just want to acknowledge that there's some sort of behind the scenes work that happens with this of, sort of standardizing those scores across the different groups to account for how many people were in each one, and to sort of make cutoffs of what sort of moved to the next round in this synthesis. But really being intentional about, for example, if cancer was number 6 in group 1, but it was number 1 in group 4, that those would sort of get combined and sort of move up a ranking based on some of the scoring that individuals did in each of those groups. So there's definitely some sort of back end work that happens around this. But when we presented this back to our CBRN board and some other community members, what we heard was, yeah, this definitely reflects what we heard in our NGT groups and what we hear from the community on a regular basis. So we think the process is pretty reflective of that community input we had heard and the experience in the community. All right. Then we want to talk a little bit about sustainability, and I want to be really honest with everybody that this is something we've been struggling with. So we developed the CBRN board to be flexible from the beginning. We wanted it to be responsive to the community, to the community's needs, and to sort of ebb and flow as things were appropriate for those experiences. And one of the things that we sort of recognized as we were ending our PCORI Engagement Award and moving into sort of unfunded space, our final deliverable was to have a research agenda, which is really valuable. It tells us where to go. But then we end up with, just because of the reality of funding cycles, this gap of, this funding has ended and we need to start writing grants to work on the priority areas that the community has identified. And so some of the things that we've sort of thought through and been working on is identifying a fiscal home for our board, and really thinking intentionally about this, that the university should not be the home for any funding we get for projects we work on together. The community should have ownership and power over their portion of the work that gets done. And so really thinking about what that looks like. And they were very clear they did not want to start a nonprofit and sort of have their own be their own fiscal home. And so really exploring the options for the group has been one of the points of discussion for us. Like I mentioned, that continuity between funded projects and being able to sort of sustain in times of drought, if you will, where there isn't funding to really ensure everyone's compensated for the work that they're doing in between things that are funded. And then we also ended our PCORI grant and sort of were ready to embark on grant writing just as the pandemic hit. And so in some ways that allowed us some flexibility to take a break when people really needed space and were having other challenges. But it's also been a con in the sense of just creating some tension in being able to maintain our momentum moving forward. So we're working on this. Maki, do you have anything to add there?
Just I want to mention that the sustainability piece of our board is very important, because if we got enough engagement from the refugees community when we are going to them, is because they felt like this is gonna be the chance not just to come collect data as used to be and then move away, but for them was the opportunity that they were seeing this thing to be coming back to them, and having like really good results, not just a one-time thing. So we wanted this to continue and be engaging like the community. So that's why we feel like without I think we will say everything or the challenge we're facing, but the members of community board, they still feel like they want to engage, but we still have some challenge on our road, but everybody's kind of committed to continue doing this job.
Yeah. All right. And then I'll stop. I want, before you jump in with questions, Bethany, I just want to acknowledge all of the rest of our board members and the people who really did this work. I feel like I did some sort of facilitation to make this happen, but these are the people who really made it all real.
Well, thank you you both so much for this presentation. I really like how you focused on, first the methodology of building this community-based research network, and then the use of this nominal group technique to inform your research prioritization exercises. And so I really appreciate that, and have always wondered how to do a nominal group technique, and now I know. So there are a number of questions from the audience, and we can get going with those. We have about 8 minutes for questions, and so if there are other questions, please feel free to ask. First, there were some questions really focused around the IRB process. So, I mean, that can be really time consuming. It's not fun for anyone. How did you pay people for this? How did you organize with our IRB on this process? Can you talk a little bit about that?
I would love to. So what you just brought up is exactly where we started this. We want community members to be able to do interviews with us. We want them to have full access to all of our data. And we are not asking anyone to take the city training, was sort of how we approached that. And so we said, well, what are other options? How else do we make sure that people have that access to these opportunities for the capacity building, and to ensure that we're not saying, well, you can't access the data because you haven't had this training. And so we looked at what some other groups had done, and we found an example here in Colorado of a group that had been able to do an in-person training. And then we went to our IRB and we said, we have community members who English might be their second, third, fourth, fifth language. And the intention here is not for them to read the Belmont report. The intention here is for them to understand what's in the Belmont report and why we approach research in particular ways. And they said, oh, this is a great problem to be solved. Let us put together an in-person training. And so they actually came to one of our community organizations. So that training was held in the community, which was one of the questions earlier, and did a 2-hour training. It was very interactive, a lot of case studies for people to sort of tear apart and put back together why and how we do certain things in research. So that training was one of the most sort of dynamic meetings we've had with this group. They really dug into the details and gave us positive feedback on getting that information in that format. And then we did not specifically pay them for that meeting, but rolled it into some of their other responsibilities. So for some of our co-moderators who were not on the board, their organization paid for their time to be there. They worked it into their workday. And for some of our board members who attended that, it was sort of wrapped into their meetings for that month and that commitment and stipend they were getting. So they were compensated in various ways depending on the roles that they had to get that training in.
Great. So then there's a bunch of questions around the qualitative process, of doing the analysis of the interviews that were conducted. So questions around how did you involve the community and how did you explain qualitative analysis and coding? And then practically speaking, how did you translate transcripts to English, and how did you do that analysis across multiple languages?
So I'll start with the transcription piece, and then I'm going to let Maki talk about the coding piece because he was one of our coding partners. So for transcription, like I said, we co-moderated interviews. So we had an English-speaking research person and a multilingual community partner. So in order for those to work in real life, we did have translation happening. Everything eventually ended up in English in those recordings. So we actually transcribed the English portions of those interviews. It's not perfect. And yeah, there are lots of ways that that could have been done, but so one, we had the transcripts, the recordings were sent, and we asked them to transcribe the English portions and mark like conversation in Burmese when it was in a language the transcriptionist couldn't understand. And then we reviewed a portion of our transcripts with the interpreter co-moderators to ensure that all of those sort of sentiments and ideas were retained in the final English transcripts. And then Maki, do you want to talk about, you got the trainee version of coding with us, so I'll let you talk about that part of the process.
Yes, actually, I personally participate on the qualitative analysis of these interviews. So the way we did proceed, personally, I didn't have an experience before on how to do the coding, but after I joined the research team and they explained briefly how they've been like doing the coding. So I've been giving like interview transcripts and go read them and understand what the refugee community was saying. And the benefit I think I was brought to the table was I could understand the meaning of the words the refugees were saying, because there's like some reality the research team, they couldn't understand what the meaning of those words were saying, or maybe there was like some misunderstanding of what refugees said during the interview. So, and that was kind of translating what was said, kind of help the research team, and that the group to kind of come to the kind of the same consensus, like agree on topic, because it was like a really discussions and around topics and theme. Yes.
Great, thank you. So just have a minute or two left. And so there were some questions around how can others come engage with your group, and simultaneously, how do you avoid this sort of engagement fatigue that communities, that those who often step up to participate in these sorts of things, how do you avoid that fatigue, but also can we come meet with them?
Yes. So ideally, yes, in the future, we will sort of open meetings for outside groups to come get feedback or ask advice of the board. And right now we're really focusing on the priorities that are in our research agenda. So we are really working on that balance of the work that the board wants to do and being a resource to other groups. And I also want to acknowledge, I just flipped through our attendee list. Carol Tumaya and May Tran, it looks like are both on. So feel free, Carol and May, to drop ideas or thoughts or responses in the chat as well. You guys were also deeply involved in all this work. And then in terms of the research engagement fatigue, I think particularly since we've all been in pandemic mode, that has been one of our challenges, is making sure that not necessarily just engagement fatigue, but fatigue in general and the things that are being asked of people is something we are constantly sort of navigating and checking. So I would say when we were meeting regularly while we were funded, it was always an agenda item. How are we feeling? Do we need to meet more often or less often? And acknowledging as we wrapped up our funded project also, is everybody still committed to this? Or do you want to help us find a replacement for you because you're feeling like this isn't something that still fits? And so really just having open, honest conversations about where people are with their ability to commit and their sort of passion and willingness to keep fitting this into their lives. And the only way we can do that is through honest, open conversation with them.
I can't think of a better place to end. Thank you both. So
Thank you.
it really was wonderful. I really appreciate you coming and sharing your experience. Thank you to the audience for your attention and attendance today. We did record this and it will be up on our website. And so we will be sending out more information to anyone on our learning community with a link to our blog and to the archives for this and future seminars. So again, thank you everyone. I think when you log off, there's a little evaluation. And if you wouldn't mind completing that, we'd really appreciate it.